Hi, good morning all. The topic for today is going to be posterior superior alveolar nerve block. It is one of the technique from maxillary injection procedure. It is common for all dentists for practicing in day-to-day life. So all must know what is in this class we are going to discuss about what is posterior superior alveolar block is going to be, how we are going to give you injection, anatomical landmarks, and surgical procedure. Before getting into this posterior superior nerve block, we must know the nerve anatomy and its course. Posterior superior alveolar nerve is one of the branches of your maxillary nerve. It comes from the maxillary nerve is one of the branches from the trigeminal nerve. It comes from it enters into the foramen rotundum. It supplies branches within the cranium, within the pterygopalatine fossa, and enters into the infraorbital canal, and it supplies the branches, and it emerges outside the face and supplies branches. Branches within the cranium is middle meningeal nerve. Branches within the pterygopalatine fossa, zygomatic temporal and zygomatic facial, and pterygopalatine nerves and its branches, and your posterior superior alveolar nerve. As soon as the emerges trunk goes and enters into the infraorbital canal, it supplies two branches, middle superior alveolar nerve and anterior superior alveolar nerve. And branches within the face, which supplies the face after it exits to the infraorbital canal, lateral palpebral or inferior palpebral, external nasal wall, and superior labial nerve. These are the branches. Posterior superior alveolar nerve block is one of the very important essay. It can be anticipated on your university exams. It can be sometime for twisting. It can be asked as a tuberosity block or zygomatic block. Nerves anesthesia are common. Posterior superior alveolar nerve and its branches. Areas anesthetize pulps of your maxillary, first, second, third molar, and buccal pedontium and bone over the tooth. Here, there is one point you should remember. Except your mesiobuccal root of your first molar, entire tooth or entire pedontium will get anesthetized. Indication: treatment involving two or more maximum molars when supraperiosteal injection is contraindicated or it is get failed. Contraindication when there is a risk of hemorrhage is more than an hemophilic patient or patient on the drug that can increase bleeding is contraindicated. Technique: usually a 26 gauge short needle is used. Area of insertion will be height of your mucobuccal fold about your maxillary second molar. Target area is, as usual, posterior superior alveolar nerve, posterior, superior, and medial to the posterior border of your maxilla. Landmark will be a mucobuccal fold, maxillary tuberosity, zygomatic part of your maxilla. Orientation of bevel is always towards the bone during the injection. The operative position for blocking left posterior superior alveolar block, right-handed administration should sit at 10 o'clock position facing the patient. For blocking right posterior superior alveolar block, right-handed administration should sit at 8 o'clock position by facing the patient. Angulation is very important criteria when you're giving your posterior superior alveolar block. Angulation should be upward, inward, and backward. It is going to be a one moment. Upward is superiorly at 45-degree angulation to the occlusal plane. I'm repeating again, but upward, superiorly, it has got superior, upward, inward, and backward movement. Superiorly, 45-degree angulation to the occlusal plane. Inward, medially toward the midline at 45-degree angle to the occlusal plane. Backward, movement has got posterior at a 45-degree angle to the long axis of your second molar. One must always sure that when you're giving posterior superior Alveolar block, these are the three movements: upward, inward, and backward are important criteria when you give administer posterior superior. Desired depth always is 16 mm. Place needle tip closer to the foramen through which the posterior superior alveolar nerve enters and enters the posterior surface of your maxilla. Long needle. If you're going to give a long needle, half of its one length should enter into the mucobuccal fold. If you're giving short needle, approximately 4 mm of your needle should be visible. Use of a short needle minimizes the risk of over insertion and hematoma. For children, insertion up to 10 to 14 mm. We should aspirate as soon as we inject. We should aspirate in two planes over 30 to 60 seconds. If there is a negative aspiration, we should deposit 0.9 to 1.8 ml. If there is a positive aspiration, you should withdraw. New syringes used is taken and to give posterior superior alveolar. Wait for a minute, for 3 to 5 minutes before doing your surgical procedure. Mostly complication you can anticipate is hematoma. It can be extraoral or intraoral. It is usually produced due to insertion of a needle. It's either too far posteriorly into the pterygoid plexus of veins, or sometimes the maxillary artery is perforated. Intraoral hematoma develops within several minutes, noted in the buccal tissue of the mandibular region. No easily accessible intraoral area to which a pressure can be applied to stop the hemorrhage. Your bleeding continues until the pressure of extravascular blood is equal to or greater than that of your intravascular blood or clotting. Usually, patient will complain of soreness, limitation of your movement or limited mouth opening. Discoloration is due to as a result of extravascular blood elements. Usually, we keep a digital pressure to the soft tissue, or we keep ice pack into the extraoral surface immediately, so that this ice pack acts as both as analgesic and as well as vasoconstrictor. With or without treatment of a hematoma will be present for 7 to 21 days. Thank you.